Thank you, Omar. I appreciate honored and humbled with your introduction. And thank you, Dr. Khanna, for the opportunity for me to participate in this very prestigious meeting. You have done a tremendous job over the last 12 years, and the International Society of Endovascular Specialists is honored to be part of it. You have been of tremendous help and promoter of our society, and we thank you very much for it. So the topic of my presentation is EVAR for short and angulated neck. And I would like to share the information available in the literature and our personal experiences related to this. This presentation by no means includes all available options related to those type of challenges when you do EVAR, but focuses on the aspect of dealing with a short and angulated neck. I have no disclosures related to this presentation. So what are the persistent EVAR challenges as far as the infrarenal neck is concerned? We can see here short neck, extremely angulated neck, funnel-shaped, reverse taper neck. We can see presence of thrombus or severe calcifications. And all of those things add to the complexity, and we call them hostile infrarenal neck anatomy. And this type of a hostile anatomy frequently leads to loss of seal at the proximal fixation site and is the cause for endograft late failure. This then leads to endoleaks, particularly type 1A endoleak, of course, to endograft migration and late aneurysm rupture. So what are current solutions for this type of a problem? Of course, surgical repair in those patients that are not considered to be too high risk for surgery, chimneys, snorkels, fenestrated and brached endografts, off-label EVAR, or watchful waiting. Now, when we look at the information and the literature related to the challenges of the infrarenal neck, one very important publication is by Morrison and Fillinger on so-called CHAP study, which included a huge number of CT studies that were analyzed. And one of the most common findings was that nearly 35% of men and up to 60% of women were considerable ineligible for EVAR solely based on anatomical requirements and problems related to the infrarenal neck anatomy. Obviously, this is more common in women, as you can see here. One of the most common causes for this ineligibility was inadequate neck length, which is considered less than 10 millimeters in length, and that was present in 25% of patients. Even in patients who qualify for EVAR, short aortic neck remains the greatest limitation to achieve adequate proximal seal and also durable aneurysm exclusion. And this has been clearly shown in the Eurostar registry with over 3,500 patients, where patients that had a neck less than 10 millimeters had a four-fold greater risk of proximal leak. And also, Dr. Ali Aburama reported that proximal endoleaks occurred in up to 50% of patients with aortic neck less than 10 millimeters in length at 2 years of follow-up. Now let's look at the endografts that are commercially available in the United States and are most commonly used for EVAR, such as Cook Zenith Flex, Gore Excluder, and Medtronic Enduran. And we can all see that they all have active fixation, which is important, either suprarenal or infrarenal. And also they use radial force to achieve a proximal seal. This is very important. Similarly, they all require neck lengths above 10 millimeters and most of them more than 15 millimeters in length. Now, one different thing about this travascular ovation system is that it does not use chronic radial force to achieve a seal, and there is no conventional length requirement to achieve the seal, which are very important differences that we will see later. Now, another important thing is as far as Cook, Gore, and Medtronic stent grafts are concerned, that they have limitations as far as thrombus is concerned, as far as calcium is concerned, as far as irregular or reverse taper or funnel-shaped neck is concerned. But Travascular Ovation System does not have those exclusions, and all of those are within IFUs. We also know that untreated aortic aneurysms exert pressure on the infrarenal neck and also on the aneurysm body and causes progressive dilatation and enlargement. Now, all self-expanding stent grafts transmit blood pressure to the infrarenal neck and cause outward radial force that contributes to the neck dilatation, as we will see in the next slide. The Ovation stent graft does not cause this outside pressure on the infrarenal neck, except for in a very small segment where the stent is attached just below the renal arteries, and there is no outward radial force that will cause neck dilatation. Now, several studies has been done as far as long-term follow-up is concerned and progressive neck dilatation. As we can see on the upper curve, with self-expanding endografts, after 5 years of follow-up, significant number or all of them cause progressive neck dilatation of more than 5 millimeters. This can even happen with open repair to a certain degree, but it did not happen, as we can see, with the Ovation Prime that uses sealing ring to create no chronic outward force and therefore insulates the neck from blood pressure, resulting in no neck dilatation and no late type 1 endoleak at 5 years of follow-up. We looked at the short subgroup analysis from this study, a pivotal study, at 5 years of follow-up in patients that had a neck length of less than 10 millimeters. 16% of patients treated in this study had neck length less than 10 millimeters. And nearly 1/3 of patients treated had a neck length of less than 15 millimeters. As we can see from this pivotal study, the technical success rate was 100%, and as far as safety is concerned, freedom from major events was also 100%. As far as effectiveness is concerned, related to absence or freedom of type 1 or 3 endoleak or freedom from migration, again, it was 100%. So we looked at our institution, at Texas Heart Institute, on our personal experience using Ovation stent graft platform for challenging infrarenal neck anatomy in patients that had necks less than 10 millimeters or reverse taper necks or severe calcification or thrombus-laden necks. All of those patients were excluded by standard criteria for any other stent grafts, including also Cook fenestrated Z or P branch endografts. Here is the first case. We can see that the infrarenal neck length was 3 millimeters. We performed 3-vessel stent graft or chimneys, as you can see here, and you can see the final result at the end of the procedure without any evidence of endoleak. So this is what I would call the most advanced kind of a scenario. Here is another patient with short infrarenal neck, as we can see here, of 6 millimeters, and significant calcification of the infrarenal neck. And again, we can see the angiogram pre, we can see placement of the left renal artery stent, and placement of the Ovation stent graft, and then final angiogram to analyze the seal zone, and no evidence of endoleak. And here is the third case of a patient with a severe calcification of the infrarenal neck, large thrombus at the infrarenal neck, as we can see here, and also funnel-shaped neck. So this patient had truly complex infrarenal neck anatomy. And the final result at 6 months of follow-up with CT reveals excellent result and no evidence of endoleak or migration or any other problems. When we look at our experience in 25 patients with this type of challenging infrarenal neckectomy, we can see that the average neck length was 7.6 millimeters. Reverse taper neck was present in 80% of patients, and close to 50% of patients had severe infrarenal neck calcification, and 44% of patients had a neck thrombus of significant degree. Neck angulation was 42 degrees on an average. During the procedure, there was no type 1 endoleak that occurred. At the end of the procedure, type 2 endoleak was seen in 8% of patients, and 20% of patients required chimneys to their renal arteries. When we look at the follow-up, which ranged from 12 to 34 months in 25 patients, we can see that the pre-procedure neck diameter was 22.8, and at the latest follow-up it was 22, so there was no increase in the neck diameter, and the aneurysm was shrinking in all of the patients that were studied. What is coming in the near future in the United States? This is the original Ovation IX system with a sealing ring that is placed 13 millimeters below the RO markers or covered portion of the stent graft. The new Ovation Alto system has a sealing ring placed higher at 7 millimeters from the graft material, which, as you can see on the right-hand panel, offers even better seal and more aggressive placement of the stent graft close to the renal arteries. Another innovation that's forthcoming in the very near future is the use of Nelix endovascular aneurysm sealing system to treat patients with juxtarenal and pararenal aortic aneurysm in conjunction with renal artery stent grafts. The goal is to reduce the risk of type 1A endoleak compared to TIVAR, and the benefits will be increased patient applicability and stabilization of the visceral segment for durability. So in conclusion, ladies and gentlemen, given the ability of the Ovation platform to accommodate to short, calcified, and thrombus-laden aortic necks, this stent graft, in our experience, may be particularly well suited for treatment of patients with challenging infrarenal neck anatomy. Circumferential wall apposition of the sealing ring creates no chronic outward radial force and no aortic neck dilatation. This has been clearly shown in Ovation pivotal trial results at 5 years that revealed no ruptures, no conversion, and no type 1 and 3 endoleak or migration, including stable neck diameter even in patients with challenging infrarenal neck anatomy. Also, our personal preliminary findings in patients treated with Ovation Prime platform that were outside of the eye of few with other commercially available stent grafts reveal encouraging short-term results. However, longer follow-up in a larger number of patients is needed to confirm our preliminary results. Thank you very much for your attention.
That was a great presentation and very good result with the very challenging cases. You have those 25 cases, really very challenging, very calcified, angulated, short neck, and you end up with an outstanding result. That's really great. And of course, for somebody like Dr. Krajcer, probably he done the most, as a single operator, the most endovascular therapy in the world, probably. I don't know what's your last count. I remember you're counting per 1,500 or I don't know how many you have done so far. But with those experience, definitely we expect this great result in the last presentation you have here. Thanks. Quick question actually came to my mind. Is there a possibility to put a small stent, not cover stent, but normal stent in that short neck few months before, let's say a couple of months before, 2 centimeter or so, and even maybe jailing the renal artery, let that things be as a base for putting your stent afterward. Is that been done, or is that possible to do this?
Yes, it is possible. Omar, way back, maybe 15, 20 years ago, when we didn't have a current technology available, this is what we were doing. We're placing a Palmas XL stent.
That's right.
Basically, place it above the renal arteries and below the renal arteries to alter the anatomy of the infrarenal neck, change it from a funnel shape to a tubular type, and also to achieve a better anchoring for the endograft. And then, for instance, we would use Gore stent graft with anchors that would be anchored on the Palmas XL's.
As a stage procedure, right?
Good results with that technique as well. One of the things that maybe it's worth mentioning, that Ovation stent graft below the renal arteries is unsupported, so I would not use it in extremely tortuous infrarenal neck, so let's say more than 60 degrees or 90 degrees and so on. There are other stent grafts that are specifically designed for that severe degree of angulation. One of them would be lumbar APVIC that we have used as well. This stent graft is available in Europe and other places, but is no longer available in the United States.
Dr. Krajcer, that was simply wonderful. Is there a role of a multi-layer flow modulator in these small and angulated necks?
Yes, definitely there is a role. I don't know if there is absolute convincing evidence that this particular modality, to repeat Dr. Khanna, I think that there is uncertainty as far as the role of a multi-layer stent in this type of anatomy. And clearly further studies are needed to determine if it will show to be superior or usable in this type of scenario. However, I have no experience with this particular stent.
I can ask a question, please?
Yeah, Dr. Mohammed, yeah, please.
Yeah. Is Ovation do better than fenestrated endograft?
Which
endograft? Ovation do better than fenestrated endograft in hostile neck?
No, I wouldn't say that it's better. I'm saying that in my subgroup of patients that I presented, they were all rejected by Cook as outside of IFUs. So this is a very specific group of patients that were not candidates for any other stent graft. That's my answer. I think the future of complex infrarenal anatomy and pararenal aneurysm is fenestrated and branched endografts. However, we need further improvements so those stent grafts can be used in all kinds of scenarios, but we are not there yet.
Yeah. Thank you. Thank you.
Good evening.
Thank you so much. And I think then we'll go to Dr. Rodney White. Is Dr. White, can't see him on the screen?
Yes, I'm here.
Okay. So welcome, Dr. Rodney White. I know I apologize for a little delay because of some untoward reasons, and we would be hearing from you. I mean, I think you're going to be speaking on sac sealing and multi-layer flow modulator.